So, my patient was an 82-year-old female who presented to the ER with worsening shortness of breath, which she claimed she had for over 3 to 4 days. Upon admittance, she was sitting at 78% on room air, and she was placed on 3 liters of oxygen via an oxy mask. She does have a history of acute renal failure, which has happened in the last 30 days. And when she was admitted, she had a BUN of 90 and a creatinine of 9.9, and her baseline is usually a 1.0. She is a full code and she has an allergy to penicillin. It was classified as a mild allergy, which just gave her sores in the mouth when she took it. She Currently, her diagnosis is acute renal failure, hypoxemia, and diffusely metastatic pancreatic cancer. She was diagnosed with pancreatic cancer in April of 2020, and since then it has spread to her liver, lungs, spine, and ribs. She is on furosemide, bumetanide for excess fluid volume, and she's on dexamethasone for inflammation, and Magestrol for her loss of appetite and weight loss, and also for cancer. She is on ciprofloxacin for pneumonia. She has a past medical history of hypertension, hyperlipidemia, heart failure, COPD with exacerbation, hypothyroidism, rheumatoid arthritis, and again, the pancreatic cancer with the metastases. On assessment, she claimed to have no nausea, vomiting, diarrhea. She rated her pain at a 4 out of 10 on a 0 to 10 number scale. Her vitals were within normal limits. Her blood pressure was slightly elevated at 155/69. She is still on the 3 liters of oxygen via nasal cannula, but she is now sitting at 96% on that oxygen. She was alert and oriented ×3. She had S1, S2 sounds present on her cardiac assessment, no extra heart sounds. Her rhythm was regular, and her cap refill was less than 3 seconds. On her lungs, she had symmetrical expansion, but she did have bilateral crackles or rales on the lower lobes of the lungs, mainly on the left lung. She was still claiming to be short of breath, even with the oxygen, and she did have a productive cough with sputum production. Her bowel sounds were normal in all 4 quadrants. She was on a regular diet. She said she had her last BM yesterday when I did the assessment, and she did have a bowel movement later during my shift. She isn't passing any gas. Her abdomen was soft and no guarding. She did have some tenderness in the right lower quadrant. Again, no nausea, vomiting, or diarrhea. Her urine, when I did my assessment, she did have a Foley catheter, which was discontinued later in the shift. Her urine was clear and yellow. Her skin was warm. She did complain of joint pain in her lower extremities. She had a right chest port, which was put in for the chemo when she was diagnosed with cancer. And she had a right peripheral line. And then the pain was 4 out of 10 in her chest area on inspiration. She was a one-person assist, no special precautions. She denied any alcohol or substance abuse. However, she did say that she smoked about 50 packs a year, but that she quit smoking tobacco more than 12 months ago. Her husband also died recently in May after he was diagnosed with COVID. Her COVID test did come back negative. It came back negative on the 6th. She did have a chest x-ray done, which showed findings of COPD, such as hyperinflation of the lungs and severe emphysema. She didn't have any pneumothorax, and there were also coarse increased reticular density in the lungs bilaterally and focal pleural thickening at the lateral margin of the right lung. She had a kidney and renal ultrasound due to the acute kidney insufficiency, and that showed no hydronephrosis in either kidney, but the left kidney contained 2.6 centimeters of an interpolar cyst. Her lab values were okay. Her BUN again was still at a 3.8 and her potassium was a 3.4. Her creatinine was still a 9.9. It was normal on August 4th when she came in for a checkup, and then it increased to 10 recently during this visit. Based on the assessment, I identified her problems as fluid retention and fluid volume overload, as well as shortness of breath and COPD exacerbation, and the pneumonia, which was the new diagnosis. Nursing diagnosis, ineffective breathing pattern related to hypoxia as evidenced by abnormal lung sounds, atelectasis seen on the chest x-ray, and cough with sputum production. For short-term planning, I put patient will have an O2 saturation of 94% on only 1 liter of oxygen by the end of the shift, and patient will show no evidence of dyspnea at rest and present with a normal rate of 16 to 20 breaths per minute and depth by end of shift. For interventions, I put slowly wean the patient off of oxygen as she is on 3 liters now, and we want her to slowly start breathing better on her own because she's not on oxygen at home. This is a new thing for her. Assess the respiratory rate and depth Q4 hours, as well as auscultating the lung sounds, listening for those crackles, and assess the ABG values to monitor her oxygenation and ventilation. Place the patient in upright semi-Fowler's position, encourage incentive spirometer use, encourage coughing to clear the secretions, and ambulate the patient 3 times daily just to promote the movement of her lungs. And then for discharge, in her chart, it did say that she was going home to live independently. She was being discharged to home for independent living. However, a skilled nursing facility was the recommendation. So, and being the fact that she was diagnosed with pancreatic cancer, which has metastasized to many of her other organs, I think hospice care would be appropriate for this patient. And that's it.